Incision of superficial abscesses. Fourth year students from Kursk State Medical University from Group 26. Aim of incision and drainage. Abscesses should be incised and drained before the point, and certainly before they become fluent. If allowed to progress to advantage stage, considerable destruction of the affected tissue will have occurred. In the breast, for example, this could mean functional amputation, and the overlying skin will have necrosed. Throbbing pain which keeps the patient awake at night, redness, heat, and a browny edema of the overlay. Swelling and surrounding skin are early warning features. Once an abscess has formed, an antibiotic cannot penetrate the vascular slough lining the cavity. It is only after the abscess has been incised and the slough scraped away that antibiotic, as well as the body's own cellular and humoral defenses, gain access to the cavity and eradicate the infection. Role of antibiotics. Antibiotics may abort abscess formation if administered early during the stage of cellulitis. This is particularly true of the breast, where mastitis may be resolved by cloxacillin therapy combined with manual evacuation of the milk and firm support of the organ. A caveat here is that persistence with antibiotics after an abscess has formed results in fibrosis of its walls and inspissation of the pus. The so-called antibioma is now indistinguishable from a serous carcinoma of the breast. Preoperative use of antibiotics does have the advantage that it reduces the surrounding cellulites, localizes the abscess, and thereby sharply defines the incision site. Also, bacteremia that may arise during surgery is readily combated. For some years now, primary closure of an abscess following incisions and vigorous curettage has been widely practiced. The success of this technique depends on the liberal perioperative use of antibiotic. Although primary closure is said to shorten convalescence, it's feared that it may increase the risk of recurrent abscesses. Antibiotics. These are started on a best guess basis in regard to the type and sensitivity of the organism. Cloxacillin is suitable where a penicillin-resistant staphylococcus is suspected. As in a breast abscess, a combination of ampicillin and lincomycin may be used where one of several organisms could be responsible, as in a perianal abscess. In the event of penicillin hypersensitivity, a cephalosporin may be substituted. The initial dose should be parenteral, lying out of the trolley, a per-sterile set consisting of a small kidney tray, a gallipot, a knife handle, a sinus forceps or hemostat, and a blunt curette is handy. Sterile gauze with cotton wool, a suitable drape as well as sterile knife blades should be available. There should also be a sterile container for collecting a sample of pus. Methods of incision and drainage. Preoperative evaluation. Infection may unmask latent diabetes. In established cases, may herald the onset of ketoacidosis in the hyperosmolar state, leading to dehydration. Infection is also prone to occur in patients with renal failure and those with blood dyscrasias. Curettage may result in brisk bleeding, and this could be embarrassing in an anemic patient. Meaningful urine and blood tests should be arranged and appropriate measures adopted to deal with expected problems. Anesthetic. It is preferable to employ local or regional anesthesia for superficial abscesses. Only this way can the slough be adequately curetted. Locally disrupted and the deep component of a collar stood abscess negotiated. The procedure may, however, be conducted with general anesthetics. For the patient with big abscesses, or abscesses localized at a particularly sensitive area. For full sedation, the patient needs to come to the hospital duly starved and approved by the doctors to the procedure submission, being allowed to hum after regaining consciousness. After following the rules for the procedure, physician infiltrates local anesthetic, usually 1% lignocaine or novocaine solutions. The steps of operation. It is best to shave the affected part atraumatically under anesthesia. Scrub up and put on sterile gloves. Clean the skin with iodine and spirit in the usual way. As mentioned earlier, a small abscess may quite simply be lanced. For an abscess situated in a deeper plane, incise cautiously over the most prominent part of the swelling and achieve final thrust into the cavity by means of hemostat sinus forceps. Open the jaws of the instrument while withdrawing. The incision may be extended with a knife blade, or alternatively, an ellipse of skin may be excised. In the perianal region, a cruciate incision is made, and the corners are trimmed off. In the breast and in the neck, where a cosmetic effect is desirable, incisions may be planted along Langer's lines and skin creases. In the axilla and groin, on the other hand, it may be prudent to incise along the line of the underlying vessels. Insert a finger into the abscess cavity in order to break the loculi. Similarly, with gauze wrapped around the finger, scrape off the slough till fresh blood oozes. In the axilla, neck, and groin underlying vessels may be vulnerable to damage during this maneuver. In a smaller cavity, the slot lining it may be abraded by means of a pledget of gauze held on a hemostat peanut swab. Alternatively, a small blunt curette may be used. Pack the cavity lightly with the gauze wick soaked in this slotting agent, such as diluted hydrogen peroxide solution. These slotting agents should be avoided wherever neurovascular bundles are directly exposed. After proper drainage of pus and proper closing of the operative site, apply a generous cotton gauze dressing and secure with taper bandage. It is disconcerting for the patient to have his clothing or covers soaked. Dependent sites such as the breast, hand, and scrotum should be well supported. In case an abscess has burst spontaneously, excise the necrotic skin and scrape off the slough. In a large breast abscess, it may be necessary to make a counter-incision in the dependent lower half of the breast and provide drainage with a corrugated rubber drain. By contrast, the small size of a boil generally precludes incision and drainage. Boils, as a rule, left to burst spontaneously. Postoperative care. Bed rest, oral analgesia, and a night sedative should be prescribed, following parenteral administration of the loading dose of antibiotic preoperatively. It is worthwhile continue with the drug for 5 days postoperatively in oral form. With breast abscesses, a decision needs to be taken in regards to weaning. In case lactation had been prolonged, it is best to wean off the infant and give the mother stilbestrol to suppress milk secretion. In most cases, it is reasonable to continue breastfeeding with the opposite breast and to manually express milk from the affected side. Arrange to see the patient after 48 hours of drainage in order to remove the pack and inspect the cavity. If clean, only a dry dressing needs to be applied again. Otherwise, repeat the pack. Admission is advisable for reactionary hemorrhage. Re-explore the cavity under general anesthesia and secure bleeding points with diathermy or under running sutures. The wound heals from the depths by granulation tissue. As a rule, 2 or 3 weeks are required for a moderate-sized cavity to fill up and empty. Premature closure of the deeper parts of the cavity is fraught with the danger of pocketing pus. Should this seem probable, it's wise to reinstitute the pack. Now, let's watch a video about the incision and drainage of an abscess.
This is an example of a neck abscess incision and drainage. An abscess is an infection in which bacteria form a collection of pus. In the head and neck, this may result from an untreated throat or tooth infection. Abscesses necessitate surgery for treatment. This patient has a right neck abscess. Prior to surgery, the course of the facial nerve is carefully considered. This nerve, which travels just below the mandible, controls the motion of the lower lip. An incision is planned well below the path of this nerve. The patient's neck is cleaned and towels are used to delineate the area of surgery. An incision is made through the skin using a knife. Forceps are used to dissect within the cavity of the abscess. Spreading is performed within the abscess cavity. Purulent debris is expressed. Following this, a finger is used to explore the abscess cavity. Note how deep the abscess cavity is. After breaking up the loculations and exploring the entire cavity, a finger is actually released, allowing the purulent debris to flow out. As can be seen here, the purulent debris is actually very thick. Pressure is applied on both sides of the wound to express the remainder of the purulent debris. It is critical to clean the abscess cavity at the end of surgery. Sterile saline solution is used to flush the cavity of any remaining debris. Once this is ensured, a drain is placed within the wound. This allows any further debris to be expressed from the wound as the patient heals. The drain is covered with sterile gauze and the patient is awoken from anesthesia.